Welcome back, ladies and gentlemen. Thank you for staying with us. So, can we start the second part of this afternoon session? So, to begin the second half of today's session, I take great pride in inviting Professor Datin Dr. Zunaina Embong from the Department of Ophthalmology and Visual Science, Universiti, Sains, Malaysia. Her interest area in ophthalmology is mainly retina and ocular inflammation diseases, and she has a vast experience, about more than 20 years of experience in that field, for which she has received multiple excellent service awards over the years for her contribution in this field. Prof will share her view on diabetes. As you all know, ladies and gentlemen, diabetes is the main cause of preventable blindness in our country, rather globally, and it affects on she will discuss about the effects of diabetes on our eyes and the ways to prevent it. So, Prof, without much ado, I would invite you to carry on with your presentation. Thank you, Prof.
Okay, thank you, Dr. Subhash. I am Dr. Zunaina Embong from Universiti Sains Malaysia. I'm going to talk about I have diabetes, will I go blind? I'm going to share my slide first. Okay, I hope everybody can see my slide.
Yes, Prof.
Okay. Once again, Assalamualaikum and good afternoon. My topic is I have diabetes, will I go blind? Diabetes mellitus is a systemic disease in which can affect all the organ and structure in our body. So mainly diabetes mellitus will affect blood vessels. If the blood vessel affect at the brain, this will cause stroke. If the blood vessel at the heart is affected, this will cause a heart attack. And also, when this blood vessel at the upper limb or lower limb is affected, this will reduce the blood supply to the foot and cause a diabetic foot or gangrene. And if this blood vessel that supply the nerve is affected, this will cause numbness to these lower limbs and upper limbs also. And if the blood vessel that supply the kidney is affected, we can have a kidney problem. And if the blood vessel of the eye is affected, this what we call diabetic retinopathy. And one of the complication of the eye, the most common one is diabetic retinopathy. So in diabetic retinopathy, we know that this is due to the complication of diabetes mellitus. So the prevalence of diabetes mellitus currently in Malaysia about 20%, means that if we have 5 patients or 5 people, one of them will get diabetes mellitus. And among the diabetes mellitus patients, about 9% will have blindness. So in the term of blindness or poor vision, diabetic patient can have this blurring of vision or can have distortion of the image. You can see that this is the normal image, but diabetic patient can see like this, distortion of the image, or can have this black area. So this is called a central scotoma. So why this diabetic retinopathy can cause this poor vision? So to understand this, we have to start with the anatomy of the eye. This is the eye that when we can see when we look at someone. We just can see at the front part of the eye. Actually, the eye is located in the orbital cavity here. And this is the anterior part of the eye, and this is the eyelid. So the anterior part of the eye is covered by the eyelid. And this, the shape of the eye is a round shape. And at the back here, we have the optic nerve. And this optic nerve, okay, this optic nerve actually go to the brain and connect with the brain. So now we look at the cross-section of the eyeball. The eyeball has few layers, mainly 3 layers, the outer layer, the middle layer, and the inner layer. The inner layer is we call retina. So the detail about the retina, okay, this is the detail about the retina layer. The retina layer has few cells. So this is the photoreceptor, bipolar cell, and ganglion cell. From the ganglion cell, they will produce this fiber. This fiber will come out from the eyeball and form the optic nerve. And this optic nerve will go to the brain. Okay, this is the anatomy of the eye. So this is to explain the how we can see things. So this is what we call physiology of vision. To see, we need the light to enter the eye. Once the light enter the eye, this light will absorb by the photoreceptor here, by the cell located in the retina layer. And this photoreceptor will change the light into impulse. So the impulse will pass to this cell and to this cell, and from this cell we pass to the fiber here to the optic nerve, and then go to the brain. The brain, in the brain, the side of the brain that process the impulse for the vision is at here, at the back of the brain. We call occipital lobes. So this is how the physiology of the vision, how to explain why we can see things. So what happened in diabetic retinopathy? As I mentioned earlier, one of the layer of the eyeball is retina. We can examine the retina. Once we examine the retina, this is how the normal retina looks like. We have the optic disc, which is the anterior part of the optic nerve. We have blood vessel, and we have this what we call fovea. Fovea is actually the site where the light enters straight to the retina. So the light enters straight to the retina. So this is the fovea. So the fovea is very special orientation of the cell in which after photoreceptor, the other cell is arranged obliquely. This is important to make sure that 100% or the sharpness of the vision is clear. So because the oblique orientation of the cell, the fovea is slightly depressed. So here, when we cut the line here, we can see here at the fovea, there is fovea depression here. This is the normal anatomy of the retina. What happened in diabetic retinopathy? In diabetic retinopathy, we have this a lot of exudate, a lot of retina hemorrhage, and also actually the patient has edematous at the fovea. So this one, again, the normal retina, as I mentioned earlier, this is the retina layer, this is the normal fundus, and this is the layer, the cell inside the retina layer, the cell that I mentioned just now, and the most important now is the blood vessel. So the blood vessel here, the blood vessel, actually this is the big blood vessel at the superficial face, and then this blood vessel will go inside the retina and give small branches inside the retina. So in diabetic retinopathy, this blood vessel is affected. what happened in diabetes mellitus? Okay, before that, in normal people, this blood vessel, what we call capillary, is actually supported by supporting cell. This supporting cell will support the capillary. In diabetes mellitus, due to high blood sugar, this supporting cell will die. So no supporting cell. What happens when there is no supporting cell? The capillary has less support, and the capillary will burst like this, form aneurysm. Beside form the aneurysm, normally in capillary, there is a minimal leakage of fluid. This minimal leakage of fluid actually contain the nutrient to give nutrition to the cell surrounding. So the cell surrounding here get nutrient from this minimal leakage. However, in diabetic patient, due to loss of supporting cell, the leakage will increase. And when there is more leakage, it's not only fluid come out from this capillary, but also the lipid will come out. So here, when there is the lipid will come out from the leakage capillary, you can see here deposition of the lipid in the retina layer. So when we examine the fundus, we can see a yellowish deposit here due to lipid. And sometimes this aneurysm, microaneurysm will rupture, and we can have bleeding here, small bleeding in the retina. So this is due to microvascular leakage. I mentioned just now, due to a leakage, it's not only the lipid come out, but also the fluid will come out. So this is the normal retina layer. You can see here very nice arrangement of the cells. But when the leakage is, when the fluid is come out, the fluid will accumulated inside the retina layer. So this, the yellowish one, is the hard exudate. So when there is presence of a lot of fluid in the retina layer, the retina become edematous. When you compare to this normal retina, there is nice fovea depression, but in diabetic patient, the retina is edematous at the fovea. We can check this edematous cornea using this spatial scanning machine, what we call optical coherence tomography. This is the machine and this is the patient. So from this OCT, after scanning, you can see here the normal fundus, the normal retina. There is very nice layer of the retina and also very nice fovea depression. However, in diabetic patient with a lot of fluid at the macular area, you can have this edematous retina and accumulation of the fluid. As we know just now, to get a good vision, we need to have this normal fovea depression. However, in diabetic patient that involve the macular area with this leakage of fluid and lipid, so you have fluid and lipid, the macular area at the fovea is edematous. Once the light enter the eye, here, the cell here is not normal orientation, and due to presence of fluid, not 100% the cell will process the, will change the light into impulse. So maybe about 50% only can be absorbed by the photoreceptor and change into impulse. So only about 50% will pass to the nerve and go to the brain. And this will cause poor vision. And also because of abnormal arrangement of the cell here, this will cause distortion of the image. If you have a hard exudate here, the hard exudate actually will block the light from from entering this part of the retina. So this will cause black area here, scotoma. So when you have this macular edema in diabetic patient, what we can do? So actually we can do laser. So this is the laser procedure. This is the patient. We put the contact lens here, and after that the laser will go inside the eye. So this is the eyeball. This is the contact lens. So the laser will go inside the eye and just burn at the macular area. So this is the small white laser burn. Okay. By doing this focal laser, actually will prevent further vision loss in diabetic macular edema. Besides leakage of the blood vessel that cause macular edema here, there are other chemicals that also involve that stimulate the macular edema. One of the chemical is vascular endothelial growth factor. So when we have this macular edema, if we can also treat the patient with the anti-VEGF, anti-vascular endothelial growth factor, by injecting this anti-VEGF inside the eye. Once we inject this anti-VEGF inside the eye, actually this macular edema will subside back to normal. So by doing this anti-VEGF injection, is not only prevent further loss of vision, but also improve the vision. Okay, just now we are discussing about the leakage that lead macular edema. Besides the leakage in diabetic patient, there is also another pathogenesis that can occur, what we call microvascular occlusion, in which this vessel is not only leakage like this one, but also can be occluded. Once this vessel occluded, so there is less nutrient or less oxygen to the cell, and this will promote new vessel formation. So you can see here, this is a new vessel formation compared to the normal retina. This is the normal vessel, but this is the abnormal vessel. And when we look at the retina layer, this is a normal vessel here, but when there is new vessel, you can see here the new vessel formation. So why there is a occlusion here? So this is the blood vessel inside the retina. So this is the normal size of the diameter of this blood vessel. But in diabetic patient, what happened due to high blood sugar? So this will increase thickening of one of the layer of the capillary, and also can cause high blood sugar also can cause aggregation of the cell inside the blood vessel, and finally will lead to closure of this capillary. So once there is closure of the capillary, the surrounding cells here is actually do not have oxygen supply. So when the body or the eye detect that this area is not enough oxygen, so the body will release this vascular endothelial growth factor. The purpose is to stimulate the new vessel formation to supply the oxygen to this area. So we have this new vessel formation at the optic disc and also at the part of the retina. But the problem with the new vessel is actually not good. It's like a bomb, just waiting for explosion. So the new vessel is here also is not good. This new vessel is not stable, easily bleed. Once this new vessel bleeds, it can have a massive retina hemorrhage here. And this blood here will organize and form fibrosis. A lot of fibrosis will damage the cell in the retina. Like here, after the explosion, you can have this damage of the environment. So, back to the physiology of vision, that we need light to enter the fovea and change the light to the impulse. What happens when we have this blood in front of the macula? So this bleeding blood in front of the macula. So the blood will block the light to enter this part. So the process here become limited, and maybe at the it's not 100% will be processed and not 100% go to the brain. That's why we have this scotoma here, black area here at the center, because the blood is at the center. But once we have this fibrosis of the retina, here fibrosis in front of the retina, so the light also will be affected to enter this part of the cell. That's why not all the light will be processed. So the patient will have blurring of vision. Normally this new vessel affect at the optic disc and other part of the retina. The macula normally is normal. So if the patient has new vessel, they still can have a good vision. The fovea still can process the light, and you still can see very nice view. The poor vision occur only when there is hemorrhage or fibrosis. So we don't want this happen. We don't want this happen. We don't want this happen. What we need to do? Although you have a good vision, since you have diabetes mellitus, you need to have the screening. Screening whether your eye has this new vessel or not. So when to do the screening? If you are type 1 diabetes mellitus, the time of screening, the first eye examination is within 5 years of diagnosis. If you mainly we have this type 2 diabetes mellitus. So based on Ministry of Health in Malaysia, we need to do the first eye screening within 6 months after you've been diagnosed to have diabetes mellitus. If your eye is normal, then you need to do yearly eye examination or a yearly eye screening. How to screen? Normally, most of the district center, we use this direct ophthalmoscope. So the direct ophthalmoscope actually need a very skilled procedure and sometimes difficult to see the retina. So nowadays we have a very simple tool to do the screening using fundus camera. This fundus camera is user friendly. So this is the patient and this is the staff that going to take the fundus photo. Once they take the fundus photo, you can have this fundus photo. You can see whether you have a new vessel or not. So if from the screening or from the examination detect that you have this new vessel, we have to do the laser photocoagulation of your retina. Same thing like just now, diabetic macular edema. This is the patient, and the laser will enter inside the eye. So for the diabetic proliferative diabetic retinopathy, we have to do a lot of laser for this other area also. So this is all the laser burn. Okay. What happens if you come late when there is poor vision already? You come at that time, you notice that you have this massive retinal hemorrhage. Now you have to do the surgery. Do the surgery, remove this blood. Or when you come with the poor vision and when we examine the fundus, you already has deep fibrosis. Fibrosis, also surgery. We need to do surgery, remove all this fibrosis, and peel all this membrane. So from diabetes mellitus, if you have diabetic retinopathy, because diabetes will affect the blood vessel, so means that you also might have this kidney disease or might have this heart disease. So if you have diabetes and you do this hemodialysis due to kidney disease, or you have this numbness of your limbs, or you have this diabetic foot, but you never had this eye examination, you must have the eye screening urgently. This is because we want to prevent the vision loss. So in summary, if I have diabetes, will I go blind? The answer is yes. And this diabetic retinopathy can cause poor vision in terms of blurring of vision, distortion of image, and central scotoma. So what I should do? You have to do this diabetic eye screening. Love your eyes as you love yourself. With that, thank you.
Thank you, Prof. Thank you. Thank you for a very simple yet a precise presentation on diabetic retinopathy. It was very, very informative, and I'm sure our audience would have really understood, because it was very, very simple, but yet very detailed. And as you stress, that don't wait for any symptoms to go for the eye screening. Once you're already diagnosed as diabetes, it's our responsibility as the patient's responsibility to go for eye screening early, because we don't want to treat them. We want prevention. So we need to sort of intervene very early to prevent preventable blindness. Okay, Prof, thank you very much. And from the organizers, to appreciate your contribution towards this seminar, this conference, we are presenting you with a certificate of appreciation. Thank you very much, Prof.
Okay, welcome. Thank you.